Welcome to today's Explainer. I am absolutely thrilled to have you here for attending rounds. I love this format because we're going to use it to completely deconstruct the conventional wisdom surrounding acute kidney injury. Today, we are focusing exclusively on the hemodynamics of AKI pathophysiology. So, right out of the gate, I want you to forget those simple plumbing analogies you might have learned back in med school. The kidney is a highly dynamic, actively reacting organ, and honestly, sometimes its own defense mechanisms are exactly what lead to its downfall. So, grab your imaginary clipboards because we are diving deep into the cellular and vascular reality of AKI.
Okay, let's dive into this with a bit of a clinical paradox. Think about the role of tubuloglomerular feedback, or TGF, during early ischemic acute tubular necrosis. Take a second and just chew on that. We're always taught that TGF is this brilliant, highly evolved autoregulatory mechanism, right? It's designed to protect the glomerulus, keep the filtration rate perfectly steady. It's supposed to be the good guy. But in the setting of acute ischemic injury, this entire system goes completely rogue. Why would the kidney's own internal safety sensors suddenly turn against it?
So the crucial point comes down to a really fascinating, albeit destructive, four-step cascade. Let's walk through it. Step 1, the kidney takes an ischemic hit. The proximal tubules, which normally burn through massive amounts of ATP to reabsorb the bulk of your filtered sodium, basically take a beating and shut down. They just fail to reabsorb that sodium. This sets off step 2. A massive, unabsorbed tidal wave of sodium rushes downstream straight into the macula densa. Now, the macula densa acts a lot like a rigid, slightly panicky thermostat. In step 3, it senses all that high distal sodium and falsely assumes, whoa, the glomerular filtration rate must be dangerously high to be delivering so much salt. And that leads to the catastrophic fourth step. To fix this problem, the macula densa triggers severe afferent vasoconstriction. It literally clamps down the incoming blood vessel. So the kidney, which is already starving and suffering from ischemia, accidentally starves itself of even more blood. It's a devastating, self-destructive feedback loop.
Now, let's pivot and apply this to a real-world scenario. Imagine a 65-year-old patient presenting with hyperdynamic septic shock. They're in the ICU, their heart is just pumping furiously, their systemic vascular resistance is super low, and yet their kidney function is rapidly declining. They're developing sepsis-associated AKI. Now, it's super tempting for us to just lump all acute kidney injuries into the same bucket, right? To just assume the plumbing is dry. But this specific hyperdynamic state forces us to completely rethink what's actually happening down at the level of the renal vasculature.
So here's your next question to mull over. Contrast the global renal blood flow in this hyperdynamic sepsis patient with a patient suffering from classic ischemic AKI. Say someone with a massive hemorrhage or severe, profound dehydration. Just pause and think about the fundamental hemodynamic difference between those two distinct forms of injury. Are the kidneys in both of those patients just begging for more total blood volume?
Now, what's really interesting about this is the profound contrast. In classic ischemic AKI, the injury is driven by exactly what you'd expect: absolute hypoperfusion. There's a true decrease in effective arterial blood volume. The tank is literally empty and the kidney is drying out. But conversely, in sepsis-associated AKI, in that hyperdynamic state, the global renal blood flow is often entirely normal or even increased. Let that sink in for a second. The total volume of blood entering the renal artery per minute might actually be higher than baseline, yet the kidney is still failing. It's an incredible irony. You're watching organ failure happen in the midst of absolute plenty.
Well, if it's not a lack of overall blood entering the organ, what exactly is driving the necrosis? The injury in sepsis is absolutely not driven by macro-hypoperfusion. Instead, the real culprits are hiding deep within the tissue. First up, we see severe microvascular shunting. The blood enters the kidney just fine, but because of severe endothelial cell injury, that blood flow gets shunted right past the critical peritubular capillary beds that actually need the oxygen. It's like having a rushing river, but all the irrigation ditches leading to your crops are totally blocked. This creates localized ischemia and persistent congestion, what we often call the extension phase of AKI. And secondly, we have inflammatory metabolic reprogramming. Surrounded by a storm of cytokines and damage-associated molecular patterns, these tubular cells essentially go into survival mode. They alter their own function and shut down their normal transport operations just to weather the inflammatory storm.
Let's move along and see how this builds as we zoom all the way down to the microanatomical level. Here's a classic PIMP question for you. Which exact nephron segment is most susceptible to ischemic injury? And what's the precise anatomic reason for that vulnerability?
Think about it. When the blood flow gets shunted or when that afferent arteriole clamps down like we talked about earlier, which cells are the very first to die and why?
And here is the dramatic reveal. The primary victims of this ischemic trap are the S3 segment of the proximal tubule, which sits in the outer stripe of the medulla, and the medullary thick ascending limb, or MTAL. When a pathologist looks at a biopsy of acute tubular necrosis, these are the exact spots where the cellular debris and necrosis are most prominent. But to really grasp why these specific segments are so incredibly fragile compared to the rest of the kidney, we have to look at their daily working conditions and their underlying geography.
And this brilliantly illustrates the horrific trap these cells are caught in. It's basically a massive supply and demand mismatch. First, their ATP demand is astronomical. These S3 and MTAL cells are the absolute workhorses of the kidney. They are constantly pumping ions, and they rely heavily on aerobic fatty acid oxidation to generate all that energy. But compounding this is their oxygen supply. Because of the kidney's unique countercurrent architecture, this specific region is naturally oxygen deprived. It operates primarily on venous capillary blood flow. Even on a perfectly healthy, normal day, they have a marginal baseline perfusion. And finally, they have virtually no backup plan. Their anaerobic capacity is extremely limited. They can't just flip a switch to glycolysis to survive. So put it all together. You have a massive, relentless demand for energy situated in an oxygen-deprived slum with absolutely no backup power generator. The consequence? Rapid cellular death the absolute second any insult, whether that's TGF-mediated vasoconstriction or septic microvascular shunting, drops that already marginal blood flow.
Which brings us to a really provocative thought I want to leave you with today. Knowing what we know now, how tubuloglomerular feedback mistakenly clamps down on blood flow, how microvascular shunting starves the capillaries despite high global blood flow and sepsis, and how the massive metabolic demand of the S3 segment horribly clashes with its oxygen-deprived environment, how might we pharmacologically break this self-destructive cycle in the future? I mean, if simply flooding a hyperdynamic sepsis patient with more IV fluids doesn't fix the microvascular shunting, and if the kidney's own TGF is actively worsening the ischemia, where on earth do we target our future therapies? Could we somehow block the macula dense's false signaling? Could we pharmacologically force that microvasculature open? I really challenge you to think about how this complex hemodynamic reality has to dictate the next generation of kidney treatments. Thank you so much for joining me for today's explainer. Keep questioning the physiology, and I'll catch you next time.